The buzz around GLP-1s hit a fever pitch in 2023 and grew even louder in 2024, dominating news, headlines, and commercials. While glucagon-like peptides, or GLP-1s, have been safely used for 2 decades, starting in 2005, to treat diabetes, the use of these drugs for weight loss indications, both on and off-label, has gained significant traction over the past several years. It's showing no signs of slowing down and infecting multiple industries, from food to airlines to clothing. And as researchers are finding that there are significant changes and uses for these drugs that go beyond weight and diabetes, they're game-changing in terms of inflammation, the body, the heart, the kidneys, the eyes, and any number of findings that are beginning to emerge from data. There's still a lot of confusion about how to get the drugs, how to use them, side effects, what happens. Lots of terminology out there that I think misrepresents what exactly we know within the medical field that's so important for the consumer and the person who's interested in it to understand. So I'm sure our listeners will be delighted to hear from today's guest, Dr. Alexandra Sowa, who's an expert on GLP-1s, and her book, The Ozempic Revolution, has just hit bookstores and online. Welcome to Healthy Longevity, Alexandra.
Thank you so much for having me.
I'm really excited to have you on the podcast, and I know our listeners can't wait to hear more about this. It's obviously the hottest topic out there, and congratulations on the book. That's not a small undertaking.
No, but I really felt like it needed to be out in the world because people were just being inundated with clickbaity headlines and a lot of confusion. And you and I have been using these medications for a long time, and I thought we need to set the record straight, so I wrote a book.
I think it's great. I mean, I remember all the questions about it. And here at the Comite Center, I've actually been using them since the advent of Byetta in 2005. Because as an endocrinologist who practices precision medicine and healthy longevity, I knew they were a game changer for most people, women and men. So off-label, I've been using it judiciously as appropriate, but so many metabolic issues that start from childhood on that I think it was imperative to change the course of someone's life and give them something that was actually synonymous with the way the body functions, because these are natural agents that have just been extended in terms of their effect on the body.
Exactly. I really could not say it better myself. And that is a big point. People forget that these drugs have been around since 2005 and used clinically.
Exactly.
So we've just had a growing body of evidence and a growing body of medications that we can use. And it's only just in the past 2 years, as you said, that people are like, ooh, what's this? Let's talk about it. But there's such a strong safety and use scenario for these medications. And we're just now starting to see the longer term benefits 20 years out.
Exactly. And I think that, well, what happened, I believe, is that the celebrities heard about it. They got a hold of it. Then the world knows about it. And of course, we'll want it if it looks like it works. Like, and the good news here is it's not just the perception, it's actually the reality. But still, there's a lot of folks out there getting it in circumstances that might be better if they knew more about it. So I think your book is going to enlighten a lot of people.
Thank you so much.
Yeah, great. Well, let me tell listeners a bit more about you. Dr. Sowa, or Alexandra Sowa, is a dual board certified physician in internal medicine and obesity, which both require degrees and training. So congratulations on that. She's a founder of SoWell Health, which is a telehealth clinic licensed in 13 states. And with over a decade of clinical experience, Dr. Sowa has become a leading voice in metabolic health, specializing particularly in GLP-1 medications and their transformative role in tackling obesity and chronic illnesses. The full title of her new book is The Ozempic Revolution, and I think we have a copy right here, a doctor's proven plan for success to help you reverse obesity, end yo-yo dieting, and protect yourself from disease. And it went on sale just a few days ago, so I feel really lucky that Alexandra decided to come in so we can have a personal conversation for the listeners who want to tune in and learn more about this hot topic for themselves or their loved ones. I believe it's the first book out there that's specifically about this medication and what the ramifications it has on your body and what it can do to transform your health. When and why did you decide to write the book?
So you are correct. It is the first comprehensive user guide on these medications. There have been chapters and books written for people like us.
Yeah.
But there's been nothing that is for the user. So I just saw so much misinformation. And I think that the biggest misconception I see with these drugs is that people say, well, we'll just go on them and then everything will be fixed. And it's the patients who are the most successful and the happiest in my practice who understand that you actually have to put in significant work while on these medications to see the full benefit of health. And most people who are getting these prescriptions now are getting them just written off, handed electronically sent to the pharmacy, and then they don't know what to do. So I get a lot of questions on social media. How do I start? What do I need to think about? How do I eat? How do I be successful? And so I put my program, the SoWell method, into this book. So we walk people through the science, which is very important. I really think people need to understand that weight gain is not willpower. It is biology. And then they need to know the downstream effects of that biology and why we are using these medications and why they are such a game changer. So we start there. And then I talk people through all of these common questions, the misconceptions, the myths, and really present the science to them in a way that they're like, okay, this is good.
Get
it. And then we move through the elements that I think are so crucial. This is not about weight loss. It is, but really, why are we doing this? We're doing this for health and longevity. And so how do we set you up for success? So we move through habit foundations, food foundations, thought and mental foundations. A lot of this journey is mental, a lot of it, and you have to be prepared for it. And then, of course, we go through how to exercise, how to avoid side effects, and it's kind of everything that I've done in my clinical practice we put into the book. Honestly, we're busy people, and we have come to get a lot of our information from social media, but a lot of it's wrong.
Right. Don't believe everything you read, and now don't believe everything you see on social media.
Exactly.
It's the first rule I learned in medical school at Yale. Literally, my first rounds with an attending who's very famous, and I came and I started quoting the New England Journal of Medicine. He's like, Florence, don't believe everything you read, even if it's in the New England Journal of Medicine.
It's true, and you have to be discerning. But we also need things that are easy. Books might be a little old school, but it is nice to have a reference you can just pick up and read start to finish or go back to.
Right.
So that's why I did it.
Good. Well, I couldn't agree more with you, and I think that by putting an investment up front into understanding what's going to change in your body, you can own that and not feel uncomfortable and scared if you get some reflux or other effects of the drug. But at the same time, you can actually work around it and make sure that you get the benefit, because the weight loss is imperative. All of us gain weight with age because it's a change in our body metabolism and hormones that inevitably lead to weight gain. When you lose muscle, you're going to gain weight because you can't manage sugar. And so Ozempic cuts to the core of what that does, Ozempic or Monjuro, Zepbound or Wegovy. And I think that is really significant. And if people understand it, the end user, it isn't just getting a prescription and then being confused and not knowing what to do.
Exactly. And also looking at it as a short-term fix, which is what this drug, I'm not saying everyone should be on it, because once you are on it, the majority of users will need to stay on it for all of the reasons you already laid out about what's happening. And if we are giving something to the metabolic dysfunction, we don't just take it away once we get to our goals on the scale or with our metabolic markers. So again, it comes back to understanding why.
Yes, and I totally agree. In fact, I wonder if yo-yo medication should be another term we talk about, because while yo-yo dieting always struck me as being so real, because metabolic dysfunction is almost uniformly we all experiencing. I have yet to meet, as an endocrinologist, any patient who has optimal sugar metabolism. In fact, we do OGTTs, or oral glucose tolerance tests, which a lot of women while they're pregnant get, but then there's no outcomes to it. Every single person has had an abnormal response. And I think that's what speaks to why these drugs are so powerful, because that abnormal response resides in us being human and surviving. Our ancestors, it's Darwinian. So if you're going to live through famine, you better have the ability to put on food when times are good, to live off your own body when they're not, or lean. And so people who couldn't would die, and those genes didn't get passed down. So while I think there's definitely going to be a need for this in some fashion, maybe in some people for their entire life. If people relearn maybe how to work their metabolism and their hormones and are able to do that in a way that's sane, so they want to live life and not eating just two foods and never, never stopping, but really enjoying life, I think there's going to be a whole spectrum of how we manage people.
I agree. That, though, does take a level of knowledge and effort, too. And we talk about that in the book. And muscle building is a big, big part of that. And I know you'll agree with me. But that's what happens. And so much of our society right now is not focused on lean muscle mass. Our jobs, our commutes, our temperature-controlled houses. They really just, and everything's kind of made for you and it's packaged. And our food system is a big part of it, too. But there has to be some work and top down in our own homes and our own lives so that we can actually transform the metabolism.
Totally agree. And I think life is easy in some ways now, but it's to our detriment in other ways. But maintaining muscle by having enough protein, I'm sure you go into this, and building muscle with resistance exercises and weight, not just aerobic. And then testosterone, which in my field is critical because that starts decreasing in our 30s, which is why on top of children, commuting, making a name for yourself in your career, all of that comes together as a perfect storm where weight gain is inevitable almost in women for sure by the end of their 30s. In men, it takes a little longer because they have more testosterone, but it's inevitable. We all see that. And the goal is to keep our health as if we were 25 to 30 the rest of our life. And I think we can do it. And I think these drugs, as you point out, and in the book, I'm sure, which I can't wait to read, I haven't had that opportunity yet, will make a difference. So before we really continue to dig deep, because I think we can go on and on here, we both are in the same mode. Tell me a little bit more about your background and also why you got into medicine and why specifically obesity and metabolic health. Did something personal trigger that?
Yeah. And I actually talk about this in the book. I come from a family of women that carry significant excess weight. And I grew up with constant chatter of my grandmothers trying to recommit to diets, what to do next, Weight Watchers, tracking steps, going to work out, eating this way, eating that way. And I was loved, and I never took this on in my world. And it wasn't a shameful thing, but they just knew they had to lose weight for their health because people told them that, but nothing was working. My poor, sweet grandmother, she was diagnosed with cancer toward the end of her life. And one of the things that she was joking about as she was on chemotherapy and losing tremendous amounts of weight, she was like, well, at least I'm skinny now. And it always has sat with me. I wish that this field was around so I could help her. And so it always carried that. My grandmothers tried and they ate well, but something in the genetics and what they had done in their course of their lifetimes, it just led to more and more weight. Whatever they were doing was not helping them. So when I went to medical school, I always knew that preventive care was what I wanted to do. I actually started off before medical school working at the World Health Organization, and my degree was in public health from Johns Hopkins, and I wanted to affect change on a large scale. But I really did like working one-on-one with the patient. So I went to medical school, and I realized that my education was outstanding, but the majority of it was focused on end of disease care management, and that was not for me. And so I was fortunate enough to work with Dr. Lou Aroney here in New York City, who exposed me
Louis Aroney.
Yes,
yeah,
he's the best. And he exposed me to this field before really anyone knew about it, obesity medicine. And when I learned that I could not just manage end disease, but help people reverse disease and prevent future disease with obesity medicine, there was no looking back. Because as a doctor, we were told, well, tell your patient to lose weight. You'd get precepted in clinic and residency. And I said, well, did you counsel them? And they're like, well, what do you want me to do? Just give them a handout on vegetables? I think all these people generally know that they need to lose weight, but there wasn't a lot of effective care.
Yeah, right.
So I found this field and have been exclusively practicing it for over 10 years. And I just love it because I don't think there's any other place. So preventing disease makes the happiest patient.
I can totally relate. In fact, when we moved to the space I'm in now, which you got a little tour of, I was trained in pediatric endocrine, adult endocrine, and OBGYN and andropause. So I had andrology, 4 fields. And when I was at Yale, I had a triple appointment. There was no field of andrology. It was absorbed into gynecology. But the frustration I saw were largely sometimes men who could never lose weight. And the only time they lost weight was to get married and fit into a wedding dress and be looking beautiful for photos. And then once the children came, it was all over. And so we actually even see young children where they're an outlier in their family. They could have siblings, brothers and sisters, and the weight is there and it's genetic. All of this is largely genetic driven. Does our lifestyle help or hurt? It definitely hurts. If we can work towards safer lifestyle, it's fine. But as you said, that doesn't change the outcomes, because with aging, our hormones change, our metabolism changes. We may not see it initially, but that's what drives why I do what I do, because I don't want people to get sick as they get older and do end of life care. We're great at that in medicine. Come in with diabetes, come in with heart disease. Yeah, we'll tell you to stop doing this or do that. But to me, if you could see it right from the get-go. So there are tests that we actually do. We look at not only insulin, but we look at adiponectin and other things. And I can see right from the get-go in an infant that they're destined to be on one path or the other. It's like having a crystal ball. And so that's why I began in the field of precision medicine. But in your situation, it sounds like this personal effect and what you saw in your own family really wanted to make a change that was dramatic and for people. And I admire that. I think it's great because it's hard work. It's not easy. Particularly, I think a lot of people were disappointed, and that's where Ozempic gives people hope, because they realize this food noise and food hunger can be gone. And I remember the show, somebody pulled me into the Oprah special where she stepped down from Weight Watchers, who are now recommending Ozempic. And I felt I wanted to cry when I saw it, because I realized how people suffer. I see it on a one-on-one basis, but it changes your whole life. The depression, the inability to feel good about yourself because you were lucky not to be food shamed or weight shamed. But other people are not so lucky because the world gives us a different message.
That's right. So this is why I called the book The Ozempic Revolution, because it is a revolution, even how we're talking about this. Even a few years ago,
Exactly.
people were like, no, it's willpower. You're not working hard enough.
Even today,
Yes,
like
we
I
still
get that
see it.
all the time.
We
And
do still see that. And people carry
even in my
that.
own family, they're like, I can do this myself. I'm like, okay, why don't you try? And I always work with people in that direction because my family gets to see me too. But once they see that it's inevitable, and I let them experiment and tell them, listen, the data will. So the other big piece of this that you probably know well too is using a continuous glucose monitor, because that also gives you insight. I've had people who've tried desperately. They're in great shape. They bike to beat the band. They work out all the time. They do everything right, and they can't lose the 15 pounds at 30, 35, 40. Well, why don't you wear one of these, and you'll see how your life is kind of impacting your sugar vacillations. Because it's not all hemoglobin A1C.
Well, no, I mean, for years, everyone's, what's your hemoglobin A1C? Well, once your hemoglobin A1C is elevated and you're in the pre-diabetic range, you have been living with significant insulin resistance for a long time. I love insulin. We talk about it in the book, and I recommend that people talk to their doctors about getting a fasting insulin or a continuous glucose
you're not
monitor.
allowed to in some settings, like doctors get pinged. But, even with the hemoglobin A1C, which I'll talk about myself, under 5, if you have significant insulin resistance and your sugar vacillates to very low, very high, your average is going to look beautiful. My hemoglobin A1C was always under 5, but my fasting insulin was elevated, and I wake up and I'm never hungry. And that's always been my whole life, because my sugar is always slightly high in the morning. So we're all programmed, even if you look gorgeous on the outside because you're thin and you fit into clothes nicely, it doesn't matter. Underneath, your body isn't behaving, and eventually that will show with diseases. And that's what we want to stop. We want people not to get these chronic diseases that turn their life inside out.
One of the things that I think is happening with these medications is people are getting them kind of so all over the place now.
Yeah.
That people
I see
aren't
commercials every single
everywhere.
day.
And they're not doing the proper metabolic workup from the beginning, which I talk to people about and give them a toolkit to talk to their doctor. We should be looking at these labs because, again, how do we know the benefit if we don't know what we're starting with?
Exactly. You need a baseline.
It really is important.
So it does disturb me to some degree that it's so easy to get your hands on it, because you could be misled, misdirected, and then you don't know the rest of the story. Like, I'm sure you've heard, like I have, the Ozempic face.
Yeah.
Well, my mother told me when she tried to lose weight midlife that if she loses weight, she loses her face. That was her excuse. So she was an active gardener to the end of her life. In her 90s, she actually had a hemoglobin A1C that reached 6. All of us eventually, depending where we are on this spectrum, will get diabetes. It's just a matter of when. So if we could put it off till 100 or 120, that's a way of keeping our health, because high insulin or high sugars or low sugars are going to damage our organs from our heart to our brain to our liver. And that's what we don't want.
And people don't understand that
No.
the inflammation,
Right.
it comes back to blood sugar, and the inflammation is a cascade that affects every
Absolutely.
single organ system.
Yep, true, too true. So I also talk about, and I'm curious about your perspective, because I'm not a fan of either the word diet or dieting. I don't like any sustained diet because I think it's misleading. I also don't like calorie counting. I think it's an imposition on your life. So I discourage people from finding any kind of fads, because I say, if they ask me, my answer to them is just try to eat along the Mediterranean lines. Try to eat a lot of protein. Start with protein instead of a carb, fat and fiber. Fat's really important because you can't absorb nutrients. What do you, tell me why this is, like, you have more knowledge.
Same. So
Yeah.
I will have my patients embrace a way of eating. And people, when they first start working with me, are very disappointed that I'm not handing them a meal plan and telling them how to diet. I mean, really, it's the biggest disappointment. And now I start, don't even ask. I'm not going to tell you this. I'm going to teach you some basic food rules.
It's exactly what we do.
So
Great to hear someone else echo and resonate. Yeah.
Dieting is shaming, and dieting doesn't work, and it chips away at your life, and you're so right. And the people who get freedom from diets and restrictive eating are naturally gravitating toward just healthful foods and whole foods. And that is one of the things that this drug does allow. It does change your taste buds and what you actually just naturally want to eat without having to work around it. So in my food foundations, I have some of the few basic rules. One, you must eat protein at every meal.
Yeah.
And you eat it first, because with GLP-1 drugs, your appetite is suppressed, and we need to make sure that you're getting in your adequate nutrition. And if we fill up on leafy green vegetables first, you might not have enough room. So I actually, shockingly, at the very beginning of GLP-1s, I'm like, great, get your vegetables in when you can. Don't worry. People are like, but I couldn't finish my big sweet green salad. I'm like, did you pick out the chicken first? Great, let's start there.
It's a great way to do it, right?
And ultimately, as your appetite comes back, you will be able to eat more volume, and we'll go back to where that more volumetric approach. But protein first. We do need to make sure to stay hydrated when we're on these medications.
Yes.
And I'm not a big fan, and I actually wonder if we differ on this. I'm not a big fan of skipping meals, especially on these drugs particularly, because people have been using that as a tool for dieting for a long time before, and they really do lean into that. But I find that people do not feel well, do not get to their adequate protein needs if we start cutting meals.
Yeah, I think we encourage people to eat. Even what we say to them is, even if you're not hungry, you actually have to eat. But we give people a little more liberty, because some people just naturally don't want to eat breakfast, because we ask them to monitor things. It's a very hands-on kind of bespoke program here. And we tell them, okay, you're a fit, you should never fast. You should actually create some trail mix so you can always have it with you. But there are other people who might fast until 12 or 1. They're used to living like that. They don't want to stop and have breakfast, and they don't feel hungry. But then we say you have to make it up in protein the rest of the day. You have to take, so exactly the same. We give them basic rules, but still people are saying, can I talk to a nutritionist or a dietitian? And I'm like, I don't think you want to. What's really interesting is just this past weekend, one of my patients from Israel had gone to a nutritionist because she couldn't get back to the States. She's in her 40s, close to 50. And weight's an issue, and she's working out hard, and she's not sure what's going on. And she said, the funniest thing, he told me everything you've told me. He said, start with protein, you eat regularly, you try your best to keep your body full of the healthy stuff. So she meal plans and stuff. So that kind of stuff I can work with. And I'm happy to hear that it's beginning to permeate. Mm-hmm. You're absolutely right.
I am seeing a shift about this.
I think the drugs are a part of the shift. They have to be, because then you realize, I don't think we're quite at the place where people understand that genetics is a huge driver here. But I also don't believe genetics has to be destiny. I think with all the knowledge we have, if we can give people those kind of rules loosely to follow, not calorie counting, not dieting, but how you best approach a life of eating, because your taste buds might be different than mine. Your desire to eat might be different than mine.
Right. Look at us. We're so alike.
Right.
I will caveat that. And I talk about this in the book. I don't actually include it in the book, but I link it out. For some individuals, a low carbohydrate diet at the very beginning of significant weight loss can be very effective. And not for long-term restriction, but really understanding the value of a carbohydrate. So I'll have people always count protein, but for some individuals, I really need them to look at the carbohydrate count too. And if someone's hitting a plateau on these medications and they're like, it just doesn't work for me, I do think it's time to look at a very low carbohydrate diet for a short period of time. Yeah. It does tend to stabilize blood sugars. We know that people don't lose as much weight on these drugs when they're being treated for diabetes, type 2 diabetes. And we lay this all out in the book. And that's probably because metabolic dysfunction and the disruption to your metabolism has gone much farther than just with excess weight. So sometimes I do think there needs to be a little bit more targeted nutrition.
You're right. I know it dates to, because we do an analysis, it dates to your genetic variants. So there are some people who need kind of a carbohydrate focus where they lower the carbs or they take healthy carbs like vegetables and fruit and things of that nature. But even if they're having an apple or a pear, we tell them to pair it with a handful of nuts or almond butter or Greek yogurt. So those are excellent tips, and we're totally with you on that. So why is yo-yo dieting so unhealthy? As I mentioned, knowing the guy who invented it, I understood it implicitly. I was lucky years ago. What's your view of why yo-yo dieting hurts?
There's a reason I put yo-yo dieting in the title of this book, because I want it to become a thing that no one even knows about. I want my daughter to not even understand that term, because yo-yo dieting is so harmful. End yo-yo dieting. The Ozempic Revolution is going to help end yo-yo dieting.
Reminds me when I have my first book, and Jeff is out there, he'll confirm it. I had to negotiate to have precision medicine in it because I wanted data to really drive the notion that data really, along with personalizing it, will make a difference in somebody's life. Yeah, way before
it's funny.
medicine.
You do have to fight for the titles.
Right.
So yo-yo dieting, I want this to become a thing of yesteryear. What we've traditionally done is that we white knuckle it, we lose weight, we do all of the right things, but then our biology and our hormones start to fight against us to get us back to an upper set weight.
We have a new set point and we can't lose more weight, or body craves it, and we are not healthy when we yo-yo diet.
And so then you regain that weight, and then in the next year you recommit again and do something even more extreme, and then you lose some more weight, and then inevitably it comes back. Now, there might be people listening to this that say, listen, I was able to lose weight once and I've worked very hard, and you're dismissing the work that I've done. There are outliers, right? We operate in bell curves in medicine, and there are some people who are able to lose a significant amount of weight once and maintain. But for the majority of people who lose weight, once we lose, we regain again. And that causes havoc on our resting metabolic rate. And the regain is so harmful to our bodies, because as we regain weight, we are not regaining that muscle mass, we are regaining fat. So we end up with more fat mass at a higher set point with a lower basal metabolic rate. And it causes a cascade of inflammatory problems that wreak havoc on all of our organs. So we don't want to do that. And that's one thing I am fearful of in the general community using these medications. People will say, I stopped it and I regained all the weight, so the problem must be the medicine. No, the problem is that we stopped medicine. And that is something that insurance companies and the government are going to have to start to intervene on, because once you allow treatment for this disease, and then an insurance company has the ability to take away coverage, and that patient can't pay for the expensive medications, and then weight comes back on,
and disease
follows, and it's going to become so much harder to lose weight the second time, even on the GLP-1 medications.
Yes, we have not really experienced that, because I kind of tend to look at people, again, it's bespoke, so we're personalizing it precisely. So we're able to judge accordingly, and some people can be on a very low maintenance dose. Other people can come off of it and do well. But they have to start again? Okay, good. But they have to be aware. And so you're absolutely right. And it has to be a fit for each person. So these bigger theories are fantastic because they really do apply. It's re-education. It's like understanding, because I get told that all the time, well, I'm on this drug and that's why I'm losing my hair. Or I'm on this drug and that's why I have sexual inadequacy. And I'm like, no, not really. Let's talk about the biochemistry and what's going on physiologically. And that's hard because you need to have time to do that. Okay, let's go into a few popular questions. So why is the GLP-1s not a fad weight loss remedy? Like what?
Well, because as we've been talking about, this is not a quick fix, one, because you do have to put in work. You have to change your whole lifestyle. And this is not just an appetite suppressant. This is getting to the root cause of metabolic dysfunction. And GLP-1 receptors are at every part of our body. And this is not a fad, because this is a long-term treatment for the majority of chronic disease that we have in our country. And while we started off with FDA approvals for weight loss and for type 2 diabetes, we now are seeing it for other diseases. Sleep apnea just got approval, right? Cardiac prevention. Depression, kidney. I really think we're going to start to see some great data on dementia prevention.
I think so too. And I think what's interesting is this is the first time, because I brought drugs to market, peptides largely in children and adults, but this is the first time I've seen data come out of academia before it's known in the popular world. Because if you follow the academic research and people's publications, it's fascinating between cardiac, liver, brain, kidney. I'm hoping eyes have a role there, dementia, sleep apnea. There's no doubt that this has an effect because there are these landing zones on all the cells, and we make it in our brain and in our gut. And so that is, it's there in our body all the time. We've just adjusted it so that it has a longer acting effect.
So it's more powerful than what we
Exactly.
create.
In fact, when the whole field began to evolve, it was bietidyme and then Victoza or daily in 2009. And I test everything before I use it, as long as it doesn't have to do anything with my prostate, because I don't have a prostate. And I remember the Byetta, viscerally, I couldn't have, my favorite dessert is lava chocolate, cake. So I remember going out to a restaurant and I knew they had fantastic lava cake. I held it because my brain didn't want it and my belly didn't want it. Like I just couldn't eat it. And so I used to get people on the drug because I didn't go right to the weekly drug when they started happening, like Saxenda and some of the others. I wanted people to have more control over it and understand what it was doing to their body. And it worked pretty well. Now I just go straight to the weekly because we can prep them and I know what it's like. All right, let's go to who's a good candidate for a GLP-1 and who's not. Do you have some consideration beyond what the risk factors are?
Well, I do think that probably about 70% of our population could benefit from these medications from a metabolic health perspective. From a weight perspective, about 50% of our country is about to qualify for use of these drugs just based on BMI alone. Let's talk about who we can't use it in yet. So I have been having babies and breastfeeding for the past 10 years, so I'm not a good candidate for it. And because it really hasn't been studied, and what I will tell you, what I've seen in my practice is that people who use these medications before pregnancy, and it's a gift to help people lose weight. But what we are seeing is when they go off during pregnancy and then after, there's a bigger weight regain. Yo-yoing. It's yo-yoing. It really can't escape any walk of life, a phase of life. And so that's really like a big contraindication bucket for me. And I also think that anyone considering these medications just for vanity, we really need to confront difficult conversations like body dysmorphia and conversations about what societal norms on thinness are. This drug isn't about thinness. It can be about leanness, and it can be about health. But that concerns me, and I treat those patients with kid gloves because this drug is not going to fix
your image of yourself, your body dysmorphia. And you can even see a lot of women and even some men who look fantastic, but if you look inside and you do a body composition, because we're really not using BMI because that could be distorting. If you're a big person, you could be healthy, but your BMI is distorted, like you're an athlete. But you can also be tiny, and if you model fat well, you can be 40% body fat, and that's not healthy. So we use all sorts of tools to investigate that, educating a person.
And in the book, I lay that all out, body fat. Yes, we talk about it in these neat little buckets, and most doctors are just like BMI, and we put it in. But I talk about how to measure your body fat and how to advocate for that, because it's going to set apart, and probably many people lower than a BMI of 27 will qualify for these medications.
Absolutely. Anybody with risk in their family of diabetes or heart disease or dementia does, because we're now looking at genetic variants. We look at like 1,700 gene variants, and the makeup is clear. Now, will all those genes express themselves? Not necessarily. But if they do, all of us, we're not going to get out of life alive, right? How do we want to go? Do we want to live our life to the fullest with vitality and joy, and then our cells get tired and 120, we start fading, we go to sleep one night and we don't wake up? That's the dream, I think. And that means living in good health. And I think, the GLP-1s and the related substances, because of course, Monjuro and others have additional peptides in them, really are game changers for quality of life in chronic disease.
And they are. I do think that we need to make sure that we have an informed discussion. I know you're doing this, but just like understanding it all, and that this could be a long-term commitment, and this could just absolutely revolutionize everything in your life, and you're going to love it and want to stay on it. I think that that's the other part of this is like, if you're not ready, if you're coming to me saying, well, I'm just absolutely only going to do this for 3 months, I'm going to say, I don't know if this is the right time for you, right?
Or people say it's interrupting my sleep, and I have to explain to them that it might be a degree of that, but that might have to do with how you're eating or how you're going to sleep or what your exercise is. It's much more complicated. We're all extremely complicated beings.
Absolutely.
So going back to who's typical and who's not, we mentioned, of course, pregnancy and breastfeeding is still a no-no. I think it's moved, like a lot of people undergoing surgery or procedures used to be told you have to be off of it for 2 months. Now it's been changed.
Well, I would hope, but a lot of my patients get wrong evidence. And I'm like, I tell every single person, if you were going for surgery, you check with me first about what you need to do.
Exactly.
I do not want to see you stop 2 months, let alone 2 weeks.
Even going through surgery, like I have patients telling me they need knee replacements, and I'm like, no, you don't. Let's look at PRP, platelet-rich plasma, or let's look at stem cells. And it's hard. It depends on the human being and what gets covered and what access they have. But even here in New York, it's amazing.
Medicine is broken.
Let's not forget, though, thyroid cancer.
Yes, so that's the big exclusion.
Yes.
Bypass that. And I screened everybody in my patient population right off the bat. You should not be using this drug if you have a family history of MEN type 2 cancers, medullary thyroid cancer. The risk is theoretical in the human population, but it's not something we want to mess with. This is not general thyroid tumors. This is a very hyper-specific.
How do you screen patients? What would you recommend listeners talk to about their doctor?
Generally in the general population, I'm sure I know what you're going to tell. I know what you're going to say you guys do here. But I think in the general population, it's really just based on history. Generally, MEN type 2 or medullary thyroid cancers have genetic components, and you will see this in your family. So in the rare case that someone's adopted, which not actually that rare, but if that no known family history, we will do some gene digging. But the risk is low, and it's just really is, we just want to make sure that we're not doing any harm, right? That is the first tenet of medicine.
And it's complicated because there's various forms of thyroid cancer. Exactly. So the other forms, whether it's follicular or papillary, are not necessarily. Oh. And the description was in rodents. So having done research for many years, rodents don't equate to humans, rats. And the doses are so different, so I agree. But I think you want to be cautious because you don't want to fear that somebody gets medullary thyroid cancer and they've been on a GLP-1.
Right. And so, but again, informed decisions. I mean, people should be allowed to make decisions about their health. And as long as we have this deep discussion,
it's helpful. Mm-hmm. So they should listen to this podcast. And if they know people, they should share it widely. Exactly. So tell us how GLP-1s, like briefly, and what it feels like to be on the medication. Is that something you can share? Because I know having 4 children in 10 years.
Yeah, so that's interesting. Yes. So, but I have treated thousands of patients at this point on these drugs, so I very clearly know what the user experience and journey is like. So briefly, GLP-1 medications, I call them, they have 3 superpowers, and we lay this out in the book. Work on your brain, they work on your digestive tract, your gut, and then they work at the level of your pancreas and blood sugar and insulin secretion. And all 3 of those together make a very powerful medication that quiets your brain from eating bad food or excess food or snacking. It also might help you eliminate other bad habits that become quite addictive, and we see damage in parts of the brain like alcohol, drugs, even behaviors like excess shopping can be improved with the way that this medication works on the brain. And many of the side effects that people experience are related to how the drug works on the gut and in the pancreas and lowering blood sugar. But the big ones, the GI side effect ones, the nausea, the constipation, the diarrhea often come because this medication slows down transit time in the stomach, and we're getting a lot more satiety hormone regulation with this drug. And so people will generally experience some level of constipation and diarrhea, and this is normal. But it can generally be very, very manageable if you're eating correctly and you're taking the right supplements and you're being proactive about feeling better about these things. And sometimes we do need medications. I occasionally will write for Zofran, and I give a whole checklist of medications you can talk to your doctor about, that if you're really struggling with XYZ, there are solutions that we might have. I also do find at the level of, which this is the level that really affects health change, is when we work on the pancreas, our insulin secretion becomes very, very effective. We become very good at regulating blood sugar, keeping it nice and stable. That's where we see all the long-term health benefits. With that, though, there is some, it's not hypoglycemia, but we see some relative lower blood sugar than where you were. And sometimes people feel that as fatigue.
Yes, in fact, it's something I've noticed for years. If you have somebody who has a hemoglobin A1C that's elevated and tends to have fasting sugars above 100, average sugars maybe 150, they don't like lowering their sugars to 100. They feel bad and they fight it, and I have to explain to them, we'll do it very, very slowly. In fact, one thing you might find interesting about the way I approached it as an endocrinologist many moons ago is I've never put, with one exception, never put any diabetic who's labeled a type 2, although I see many versions of diabetes, so I don't even call it type 2 anymore, on insulin, ever. I worked with each one of them,
well
and now
done.
My friends.
My hero.
Right, yeah, because it wasn't necessary. And insulin actually causes you to gain weight.
Insulin
It is not a good thing.
Not a good drug.
And it's not a balance. That's what GLP-1s bring to the table. And I've asked a lot of my type 1s to go on GLP-1s. Their doctors took a decade to decide. And still now they're not really comfortable with GLP-1s. So they don't think, type 1 diabetics, where it does make a difference for them. So I think you've covered a lot. Food noise. Do you want to just say a word about that? Because you alluded to the cravings.
So food noise is interesting, and it was one of the studies that I dissected in the book. Food noise is probably the most dramatic thing that we hear about on social media. I just don't think about food. And people will tell me that I've given them hours of their day back because they're just not perseverating on what to eat next. It wasn't disordered eating. It was just how their brain worked, and they're thinking about the next meal and when can I
While
not
they're
eat?
eating one meal.
While they're eating one. And it does quiet that. What is really important to note is that in long-term studies, hunger comes back. And between about 5 to 12 months on any given dose, patients will start to say to me, I don't think it's working anymore. And they really start to panic. And then they question this whole journey because innately they go back to negative beliefs that they should never have been on this. And they'll say, it's not working. I knew it wasn't going to work. And they panic. But I ask them to look at their food log, which we keep in our practice. And I ask them to kind of look at the scale. Are you losing weight still? Are you maintaining? Yes. Okay. Are you still eating healthfully to plan? Are you still getting your protein in? Yes. Okay. Well, your hunger is coming back. And we know that hunger does come back. We shouldn't have obsessive food noise in our brains. Even when hunger comes back, that's an okay thing. Hunger is natural. These medications still allow us to manage what we eat. And even when hunger returns, we're able to maintain or even keep losing. I think that's a really important point.
It is big. I think that what we end up hearing is exactly the same. Sometimes people need high doses. Other people get away with absolute lowest dose and can't go any higher. But I think what they find is even if the hunger comes back, it's contained. They can't eat as much. Early in the days, before I knew anyone else using it, I was one of the first I know to use this. I would be told, but I can't actually finish the meal. We would work with them to understand that hunger is a natural precipitant because we can't survive if we don't get hungry, right? And most people don't. They eat because the bakery looks great. The smells are wonderful. And we're misdirected. There's clues that we're not aligned with what we're supposed to do in our body. And there are a lot of people who they're not in touch with their body. But I've had people stop drinking, as you mentioned. Depression goes away. They sleep better. And they realize that their whole body could feel better. A couple more things since we have the expert here. How much weight on average you see your typical patients lose and how quickly?
So through my practice, we see much higher numbers in the average population. But let's lay that out for the average population. With the GLP-1 weekly medications, Ozempic, Wegovy, there's about 15% total body weight loss in the population studies for non-type 2 diabetics. And then with the dual agonist medications, we're seeing upwards of 23 to 25% of total body weight loss. I would say in my practice, we see significantly more because, and I'm sure you do too, because we're doing the other work.
Yeah, the factors that help this drug do what it needs to do, but changes your whole system physiologically. So,
and when you look at the populations and how they controlled these studies, it really was set up for a general population that was getting a medication. Now, there were some calorie restriction, there was do some exercise, but it wasn't targeted to strength training and it wasn't targeted to macronutrients. So there's a lot of room for continued study on how we can maximize the use of these drugs.
That's good. That's great. The other big topic that's on TikTok, if you're on TikTok, is Ozempic face. We alluded to it. I get asked that all the time, and I'm like, anyone, when you lose weight, you'll lose your face because fat can disappear. But you can actually go back to resistance training and make sure that the way you eat, what's your feeling on that and where?
Absolutely. Well, first off, no patient of mine has ever said I regret the significant improvement in my health and life and my weight because I have loose skin. Nobody in reality. Do you know?
And skin improves.
I do know the PR person who was behind coining this term. So
I'm
just going to leave it there. I think it
it's catchy.
May or may not have come from a plastic surgery office. So we do lose laxity as we lose weight, but you can do, and it will hit with later years, it becomes a little harder, and my younger patients have more rebound of their skin. There are two things you can do. You are going to eat protein, and you're going to prioritize it, and you are going to strength train, and that will have a big, big improvement. There are some studies for general weight loss that show that collagen as a type of protein, which is an incomplete protein, can have added benefit too for skin
collagen
laxity.
Applied to the skin or collagen
Ingested.
ingested?
So we want to have our complete proteins, but then collagen can have an
What do you
added
recommend?
benefit.
Do you have a specific recommendation? I know you have your own line of foods.
So I created a line of products called the GLP-1 support system. It's called the SoWell GLP-1 support system, and you can find us in retailers or online. But it was my supplement recommendation that I was recommending over and over to people because really you need it. You need electrolytes or salts in your water to feel well and to stay hydrated. And you need easy sources of protein. And fiber is so helpful for the oscillating constipation diarrhea. So we created a stick pack system, 3 stick pack. You could just keep it where you go. And our protein does have collagen in it. And I really dove deep into the studies about it. And it's just an added boost to your body making its own
That's a great tip.
Collagen.
We haven't really been doing that, so I love it.
And then the science is there. And you're going to have some naysayers, but like collagen isn't going to hurt you to consume it, right?
Yeah.
And then also good skincare throughout the process. I will go see your friendly dermatologist, and you might need to say hi to the plastic surgeon. But you know what? Your insides are going to look useful.
Well, you know,
fix the outside.
It's true. But you know what? The plastic surgery I find that happens is some people have a lot of leftover skin because they were massively obese. And when this shrinks them down, they want to do something to make their whole body feel good. It isn't a dysmorphia. It's like, I want to be able to wear a bathing suit or a bikini, and I've never been able to. So I think it's amazing.
And it can cause health problems. I mean, really, when we have excess skin like that, there are issues. But you know, that's for very significant weight loss. I feel like a lot of these headlines with Ozempic face, it's just, yes, you got a little thinner. We all do as we age.
Right, exactly.
Too,
More wrinkle show.
fat.
I want to add one thing because as an endocrinologist, and particularly I'm a reproductive endocrinologist, so I trained in every field of endocrine, in fertility, all the way to pediatric, growth development, adolescence, menopause, andropause. I stopped at geriatrics because I think that's very complicated, and it's not as easy as taking care of little kids, actually. Testosterone falls in your 30s by 1% to 3%. And patients who are maturing into their 35 and beyond, that's when disease starts hitting. And that's when we lose muscle. And that's when sugar emerges. So we actually look at testosterone levels. We specifically want to look at free testosterone because even in women with birth control pills, if you have young patients, you're suppressing testosterone and it's not going to help them. So a lot of women blame weight gain on birth control pills. No, what's really happening is you're suppressing your testosterone. So a little bit of testosterone cream can make a huge difference. Now, it's not formally approved for women. I've been doing it over 30 years. Sloan started doing it. Actually, I had a protocol for women with breast cancer whose doctors refused to give them any hormones, but they didn't want to live. They felt awful when they had total wipeout of this is years ago. And I created a protocol at Yale that was, well, we'll give you testosterone, and their whole life turned around. So that's a third leg.
That's not something I do in my practice, but I am willing to learn because now I'm opening up to in the menopausal population and the perimenopausal population, especially, but I hadn't thought about it.
Yeah, birth control pills. In fact, there's data out of Einstein that shows women on long-term birth control pills also lose more bone and higher risk of osteoporosis. but testosterone's falling and we ignore it in women. It's not just a male hormone, it's a female hormone, as is estrogen, pregnenolone, DHT, DHES. All of those occur in both sexes, just to varying degrees.
So I'm curious, what form of birth control, if any, are you recommending?
Well, there aren't choices with testosterone. So any form that works in terms of the birth control piece, but add testosterone cream. It's not going to increase for women. For men, it's they have much more testosterone, but even men as they age, I tend to use a peptide called HCG, or human chorionic gonadotropin, and it stimulates the negative feedback loop. And because it isn't the testes that's not making it, it's the fact that the body doesn't recognize that circulating testosterone's low. So with most men, if it is low, because it's almost inevitable, but it could happen at any decade of life. It's not like women where we hit a wall at 50 because we've had our last period within a year and that's it, and our ovaries are shut down. In men, they still make hormones. They just don't make them as effectively because the brain there's no communication. And so by stimulating either their own testosterone, which you can do for many decades, or giving them testosterone, which is a lot more cheaper and insurance will sometimes cover it. So I tell, because we have actually more men than women from the work I'm doing here. Even though I started this with women's health in 1992 at Yale, I opened up a women's health center there. So both men and women could benefit from testosterone, especially women.
Yeah, I've learned something today.
Me too. You've answered some of these questions, so I'm delighted. I have to repeat it, like other health benefits. What's the impact on our nation? I don't know if you want to go there. Okay.
The health benefit or how is this going to change the nation? I have a really big issue right now when I see weight gain and health being politicized, and there is a movement that we should be able to fix obesity and chronic disease through food alone. And for all the reasons that
How well has that worked?
Exactly. And for all the reasons you laid out, we are living in a society, even if we were to make it the most perfect bubble society, we are living in a world where we cannot replicate how we came to be as humans. And we cannot treat this overwhelming epidemic of chronic disease and obesity with food and lifestyle alone. We need to look at the prevention differently than the treatment. And in no other disease state are we expected to do
willpower.
Exactly. The prevention is the same as the treatment. I mean, even looking beyond willpower, if you say food as medicine, I believe in it, but also once you get to a disease state, no one is saying that the prevention should be like it was.
Well, now
disease,
you could get anything, but it's like Hippocrates went to, let food be thy medicine, let medicine be thy food, but we don't live in that world anymore.
We don't.
And we live much longer lives when disease does emerge, because of aging.
Right. So I think that this has massively big potential to change our country and the way that we distribute money and in our medical system and how we have to treat end disease. And we really need to think critically about it. But please do not listen to the people that are saying that we should be able to do this all through.
Totally agree. Because it's also predestined. But I believe your genes don't have to be your destiny, but it actually is predestined. I see it from little kids to adults through the end of life. There's a reason we have a $4 trillion budget, and every single part of society wants to get into healthcare, from CVS shutting down cigarette sales to advising, and even telling a lot of times the pharmacists won't fill prescriptions I give because they have the right to say no. And it makes me insane.
Makes me crazy.
Me too. I actually have given them my book from years ago and said, here, there's insulin resistance. Can you look at it? And I've almost written and I gave up because I felt like it's just such a massive misunderstanding.
A different pharmacy.
Yes, exactly. So a final question along GLP-1s. Yes. And also let me make a point too, that it doesn't stop with Ozempic. Like we have about, I would say, a third, 25% to 30-something% patients cannot tolerate just Ozempic because of the reflux and the effect on the GI tract. Poorly tolerating it, even at a low dose. So Monjuro and the combination of a GIP with a GLP-1, and there's more coming down the pike, has been also a game changer for some people. So that's a place to go. It's not stopping with just GLP-1s, which is great.
No, yeah, we didn't touch on that. There are more hormones. We've got their triagonist coming out hopefully at the end of next year with even better GI tolerability.
I know, it's amazing. So I'm pretty excited with that. I've rarely had a patient who couldn't tolerate Monjaro when had to stop the Ozempic because they were vomiting, and nothing they did made a difference, because we use Zofran too sometimes, or Linzest for the diarrhea. And then we ask them to balance it with us because we're working in partnership, as you do with your patients. So what's your hope on GLP-1s and all the other peptides that are coming along and its impact on the health of our nation?
Well, I hope we are able to really pivot back to prevention and live much healthier, longer, productive lives and less on end of disease, end of life management. My big hope is that these drugs become a lot more accessible and affordable, and we are starting to see some positive things from a government top-down level and indications that will allow Medicare and Medicaid to cover weight loss drugs for the first time since the early 90s. So it's really my big hope. We need to be able to make this affordable and accessible for everyone like it is in Europe.
I think that we're getting there. I see a lot of patients who run their own organizations, they're CEOs or founders, and they're a name brand kind of organ, and they've been fighting for it because they realize that it's not available universally, and insurers don't want to pay for it because they don't see the end benefit. They just see the current effect on their quarterly reports. But so be it. I'm totally with you. That's why I do the work I do.
It should be
as
considered
well.
malpractice from an insurance level.
I agree. And then they write it out of the plan so you can't get it. It's disturbing. So finally, it's a question I'd like to ask everybody. If you were sitting next to someone on a plane and inevitably you get to be talking unless you're trying to read or sleep or something, and they find out you're an obesity doctor, and they have a question, a burning question, and you're nice enough to answer. And if they say to you, what is the one thing I can do to improve my health or live life to the fullest? What would be your answer?
Only one?
Well, let's say you can have three. One would be a great place to start.
I've got three. We already talked a lot about this, but I do believe whole foods and prioritizing your protein are very important. Next up, strength training. We need to make this more of the norm. People need to look at it less as something that's enjoying. Like, I'm a person who loves exercising, and more as I'm a person who is making my bones and my muscles strong for long time, healthy living. And then finally, this is something that I find very important. I really think we should be prioritizing sleep hygiene from a very, very young age and doing everything possible. I'm a big, big believer in sleep, good sleep, quality sleep, set schedules, and I do everything in my home to give my children that structure. So
you getting sleep?
People all the time joke, like, you must have pulled all-nighters writing this book or in medical school. I have never once in my whole life. I'm not bragging, but I kind of am. I just really feel like sleep is a beautiful gift, and we need to embrace it and use it to restore.
Okay, well, thank you so much. This was so much fun. I feel like it's a topic I've lived for 20 years, at least the GLP-1s, and you've become an expert, and I think it's fabulous because you're making a real difference in people's lives.
Thank you.
I want to mention your book again, Ozempic Revolution, and the fact that you have your own line of products, which is an amazing accomplishment, and having a child in that time frame too, a 10-month-old, your only girl in a family of 4, 3 boys and a girl. And I'd love you to share the details of your social media.
Yes, so you can find me across all platforms at Alexandra Sowa MD. Our company is at getsowell.com and on social at getsowell. So, and books you can buy, go support your local bookstore, but you can get this on Amazon. We're published by HarperCollins, and we're so happy to be out in the world. So thank you for the conversation.
This was so much fun, really. Thank you.